Thank you, Mark, and yeah, apologies again for the technical issues. I'm currently not in Vietnam. I'm in Ealing Hospital, which is in West London, for those who know London, because I come back and do some clinical work here in the ID department. So we thought it'd be easier while I'm here, also because of the time difference, but technical issues made it slightly worse. But anyway, so I'm going to talk today about some clinical aspects of dengue, but also touch on some of the research that I'm doing in Vietnam, and then there'll be time for questions at the end for anyone that is interested. So let's see if I can move this forward now. There we go. Let me know if there's any delay or any other issues. Okay, so I'm not used to presenting in this format. So dengue, the WHO named dengue one of the top 10 threats to human health. And that's really because it's been emerging across the globe in the last 20 years. And also because we don't have any particular therapeutics, and we've got one quite poorly effective vaccine. And if you get admitted with severe dengue in some parts of the world, you can have up to a 20% chance of dying. So it is a very neglected disease, and one that is becoming an increasing problem around the world. So this is the sort of current global dengue burden. We're a sort of epicenter in Southeast Asia. So we're hyper-endemic in southern Vietnam. And like the rest of Southeast Asia, a huge burden in India. And for Africa, we know that all four serotypes are circulating. You don't tend to get these explosive outbreaks that we do in Southeast Asia and in Latin America. It's probably going and has gone under the radar in Africa for many years. And we know from some travelers that have come back, particularly from areas like Mombasa, but also in West Africa and in Angola, that dengue is being transmitted, and there's current mosquito transmission studies ongoing in West Africa, and all four serotypes have been isolated from there. So it is a huge problem, and it's an emerging problem, and it will only get worse. So with climate change, we know that one of the mosquito vectors, Aedes albopictus, is already established in many new parts of the world, like in southern Europe, but also southern states of America and also southern China. And with the establishment of the vector and a warming climate, we expect to see more dengue outbreaks in new areas. And these are the two primary vectors, Aedes aegypti and albopictus. Aegypti is the predominant vector that we see in Southeast Asia. It's a highly urban adapted mosquito, so it breeds in very small sort of rubbish around people's households. So it's very adapted to the urban environment, and that's why dengue is predominantly an urban disease, but you can also get it in rural areas. And this is the sort of current and future prediction for the environmental suitability for dengue. And you can see where it currently is endemic and where we are expecting the expansion. So in Africa, you'll see the expansion down into South Africa, and also into other parts of East Africa, and also in the sort of range where dengue is sort of on the border of transmission, like, for example, in southern states of America and southern China. So it will become more of a problem. So moving on, so apart from the public health burden that dengue poses, there's also a huge economic cost to many countries that it affects. And you can see here, just for Southeast Asia, the cost that dengue causes for many of the endemic countries. And these are low middle income countries, so this is a huge burden for them. We've done some work with health economists here in Oku in Vietnam, and it was one of our students looked at the productivity costs from a dengue episode in Asia, and you can see the sort of estimated global economic burden is huge, so sort of $8 billion a year lost in productivity costs. So apart from the public health burden, we also have to bear in mind what individual costs are for people. This is a disease that affects young people and children in endemic areas, but also young adults in Latin America, for example, and other countries. So the cost of sort of work loss and also people having to take time off to look after the kids is huge. So the disease, so in 2009, the WHO reclassified dengue. It used to be called dengue hemorrhagic fever and dengue, and now it's just dengue and severe dengue. And then there's this warning sign group to help clinicians triage patients. So those who are at risk of developing severe disease. And then severe dengue encompasses these sort of three areas of plasma leakage leading to shock, hemorrhage and organ impairment. And severe plasma leakage and shock are the most common manifestations of dengue. So all dengue patients get an element of capillary leak, and then some patients go on to get sort of decompensation and then hypovolemic shock. Hemorrhage is not a huge feature, severe hemorrhage, unless patients have already had like a couple of episodes of shock and organ impairment as well. And those tend to happen more in adults than kids. Kids tend to get more of a pure shock. So these are the phases of dengue. So by the time a patient presents to you, it's likely that their viral load and their virus is already peaking once they present to you with symptoms. And then that declines over 4 or 5 days. The host inflammatory response follows. And this capillary leak that I mentioned, we don't really know when it starts, but likely it starts fairly early on and then manifests in the critical phase, which is this day 4 to 6. And it manifests as sort of, fluid accumulations like pleural effusions or ascites, and also intravascular volume depletion. So that's when patients will present with shock and the other severe manifestations. So this is what severe dengue looks like. So as I mentioned, it's either, well, you can get all three. Shock is the most common, from this increased capillary permeability. And then you can get this minor hemorrhagic symptoms, usually from thrombocytopenia. All dengue patients will have low platelet counts, and they can also have a coagulopathy. And of the organ impairment, liver is the most commonly affected, and nearly all patients will have an element of transaminitis. And then you can also get some renal failure, but again, it's usually associated with shock. And you can get a myocarditis, which is rarer, and also you can get dengue encephalitis. Again, that's fairly rare. You might see 1 or 2 of those a month. And these are the sort of bleeding manifestations. So it's usually like something that's been provoked. So for example, on the left, you can see where a patient's had blood pressure cuff, and you can see these linear petechiae after they've had the blood pressure cuff inflated. And then the middle pictures was after we inserted a femoral line and the patient had a very large bleed. So we try to do as minimal intervention as we can. So just not even any IM or any intervention at all, because they do bleed. And if you do have to put it in lines or do anything, we would always cover with platelets. And then other patients can get mucosal bleeding, and that is one of the warning signs for progression to severe disease. So dengue in Vietnam, so in the south where I'm based, it's a tropical climate. So we see transmission all year round, but it peaks in the rainy season, and it's sort of varying size. Seasonal epidemics happen. In Hanoi, which is in the north of Vietnam, which is where they actually have cold winters, transmission gets stopped during the cold winter months. And it's more of an emerging disease up there, and that would be sort of similar to some of the cities in sort of Latin America, for example. So this is just showing where Vietnam is and what such a long, thin country, so it's like 1,000 kilometers. So you can get on a plane in Hanoi and it'll be cold and you'll be in a coach, and then you come down to Ho Chi Minh City and it's boiling. So it's a really varied climate, and also the epidemiology of dengue in Vietnam is quite different. And we work both in Hanoi and Ho Chi Minh City. And this is, well, the top half of the slide is what I think a lot of people still think Vietnam looks like, in lovely quiet streets with bicycles, but in reality it's the lower pictures where it's now, the traffic is a huge problem. Most of my days I'll get caught in a moped traffic jam on my way to work, as you can see in the lower right. It's, yeah, urbanization is has been a big problem, but it's still a beautiful country, and I would encourage everybody to come visit. So this is the Hospital for Tropical Diseases in Ho Chi Minh City. It's a tertiary referral center for infectious diseases for all of southern Vietnam. So that gives us a catchment area of about 40 million people. So relatively rare diseases are common for us. So I was just telling Mark how we will have a whole ward for tetanus patients. We see rabies, we have a whole ward for encephalitis. So it's really is a remarkable place to work. And it's also one of the tertiary referral centers for severe dengue. So we see about 500 severe dengue cases in our ICU, split. So, well, there's still a little bit more pediatric severe dengue, but adults are also increasing. So we'll see about 200 severe dengue cases in adults every year. And it's a huge burden for the hospital as well. So in a bad year, we can see about 15,000 admissions. And remember, this is usually focused in the rainy season. So we can get up to sort of 50 admissions a day, and they'll see hundreds of patients in the outpatient. So it poses a huge burden for the health system in Vietnam. And this is the pediatric ICU, and every single patient, you can see that every single bed, this is the rainy season, is full of a case of dengue shock syndrome. So it can completely sort of collapse health systems during the rainy season, where it will completely overtake the hospital. So the current way of diagnosing dengue is, it depends on when you see a patient. So in the first week, you can identify the virus in the blood using PCR, or you can use NS1 antigen rapid tests or an ELISA. And then you can also do serology. You can do acute and convalescent serology. And you can get these rapid tests that combine NS1 antigen and an antibody test. But there are various challenges regarding diagnostics. So the PCR, you need a centralized laboratory, and it's expensive, and you've only got this narrow window when they're viremic, which is usually 4 or 5 days. The NS1 antigen tests, not great sensitivity, especially for dengue 2 serotype. And then for the serology, you've got the issues of cross-reactivity with other flaviviruses like Zika. So diagnostics, we're still working on improving them, and we are working with a team at Imperial College where they're developing like a lab on a chip device, which would look at the quantitative PCR and quantitative viral load, and also serotype, and that's being developed through Pantelis Georgiou at Imperial College. And we're also working with him on wearable monitors that I'm going to go into a bit more, which is part of Innovation's Wellcome Trust project that we're doing. So just moving on to the research that we're doing at OCRU now. So I'm not going to be able to go through all of them. I'll just touch on some of the technology innovations that we're doing, and also some of the clinical trials. But these are the other areas that we're working on. So we're doing physiology studies. We have got, through Bridget Wills, a dengue-controlled human infection model that is just currently in the sort of investigation stage. whether we can do that in an endemic country. And then the other areas are just in pathogenesis studies and immunology and some transcriptomics and biomarker work. We did have an insectary that's now closed down. Cam Simmons used to do a lot of that work, looking at mosquito viral transmission and blocking using Wolbachia. And I'll mention that right at the end, but I'm not going to dwell on that. So just to talk a little bit about some of the technologies that we're working on. So what are the challenges? Well, so this is sort of some pictures of a high-income ICU, and you can see just how much equipment's necessary, and imagine the cost of funding a high-income ICU. And so what we're trying to do is to do this sort of monitoring, but at low cost, but keeping the same quality. So specifically for dengue, we're looking at trying to identify which patients are at risk of severe disease because of this problem of seeing like thousands of patients a day in outpatients. What we really need to do is only admit those that really need admission, so those that really need supportive care, and try to evaluate better who's sort of leaking so much fluid that they will decompensate, and then how much fluid do we give, because we know that they will continue to leak, and giving too much fluid is associated with poor outcomes. So those are the kind of main issues that we're facing in the endemic setting. So what we're trying to do is develop a low-cost wearable device that would continuously monitor patients, not only in hospitals, which would save nursing care and time, but also could allow patients to be kept out of hospital and we can monitor them remotely. And we are also developing a clinical decision support system, not only from utilizing sort of routine lab results and vital signs, but also we're trying to incorporate some of the physiological data that we're collecting from the wearable devices. And then also within the innovations project is sort of medical imaging work package where we are using point of care ultrasound to assess cardiac and volume status, and also lung ultrasound to see how much fluid is in their lungs. So as I mentioned, this is part of a much larger Wellcome Innovations Flagship Award that we got a few years ago, which was a collaboration between Oxford's Imperial, King's, ETH Zurich and Melbourne universities. It's not only for dengue, it's also looking at sepsis and tetanus and various other, and TB as well. And the implementation side of things are here at the Hospital for Tropical Diseases. So I'm just going to mention some of the work that we're doing on the wearable device. So the wearable device is incorporating PPG, so just what everybody would use for usual pulse oximetry, but actually extracting more information from that. So actually looking at the pulse waveform and using machine learning and AI to extract features of the waveform which are associated with clinical outcome, but also with vital signs and intravascular volume. And we have got some background already in using this kind of technology. And this has actually just been published this week, which was using the compensatory reserve index, which again was just using feature extraction from waveform data that was developed by the University of Colorado. And we assessed how it would work in dengue. And it was able to predict up to 6 hours in advance of a patient developing reshock. So if you're interested, sorry, I meant to put the reference there, but it's just been published in BMC Medicine this week. So the issues that we're trying to address at the moment is because there are lots of wearable devices that you can get commercially, but they're currently still quite expensive, and also people moving around, there's poor signal quality and artifacts, and also are they, we need to make sure that they are appropriate for the local setting and people are happy to use them, for example, in Vietnam. So part of the innovations project was actually using first of all, just collecting some physiological data using commercial wearable devices. So one that we're using is called SmartCare, which was actually developed by Oxford University and is now like a spin-off company. And they're going for about $100, so still a lot cheaper than some of the other wearable devices. And we're putting them on patients as they come in, and then we're currently analysing the data to see if we can predict various different clinical outcomes. But in addition to that, we're also developing our own wearable with some very clever engineers at Imperial. And in addition to just PPG, we're also incorporating other parameters that we would use in monitoring dengue patients, like hematocrit and heart rate and SATs. And hematocrit we measure routinely in dengue patients because it's a marker of, and when it goes up, it's a marker of relative heme concentration as fluid leaks out of capillaries. So we're trying to incorporate all of these into one wearable device, and that's currently it actually looks slightly different to that picture now. We're sort of in phase version 2 of this device called Escape, and it's currently under evaluation in Vietnam at the moment. We've recruited about 30 patients and are hoping that will be another alternative low-cost solution. So moving on to some of the other technologies that we're developing. So another one is a clinical decision support system, and CDSSs are being used in various areas of medicine. One that we're developing for dengue is really what we want to do is help clinicians who are already overloaded with patients to really sort of recognize and help manage patients who may go on to get severe dengue. And we want to try and identify those who are going to be at risk of shock, but also help with triage of the patients, because as I mentioned, there's huge sort of influx of patients that can suddenly happen in the rainy season. And so we've done a lot of groundwork to see how would this CDSS fit into the sort of clinical workflow in Vietnam. So we've done this with some of our social scientists and implementation scientists at Oxford and in OCRU, and we've done a series of workshops and really work with people who will be using this tool to understand, what do they want from a decision support system, what is needed, at what point are clinical key decisions made, and how would it fit into work in the hospital for tropical diseases, and then hopefully expand that out to more provincial hospitals, especially hospitals that aren't used to seeing dengue. We feel that this could be the most valuable setting. And in developing this tool, we've used some data that we've been collecting at OCRU for the last sort of 20 years. So we've got a lot of data, up to actually more than that now. It's about 10,000 patients that we've entered and used to train the model, and that's work that's being done at Imperial College. And while they're developing the sort of back end of the tool, we've been continuing to sort of work with the end users in Vietnam to see again what they would want. Would they want it on their phones as an app, or would they want it on a web-based on their computers? Can it fit with the electronic patient records and lab system that we already have? Knowing that already overworked doctors don't need to have any more work to do, but it's something that would really try and help them display various key lab results, for example, and other tests that they would usually use, and try and help, and also integrate the Ministry of Health guidelines. into the system as well. So that's work that's still ongoing, and this year we're hoping to run that as a trial of the completed CDSS. So various different innovations happening, and because of the rich data sets that we have at OCRU, and we're adding to that all the time, we hope that there'll be more opportunities for iteration of each of these technologies. So moving on to a slightly different area now. So as I mentioned, identifying which patients are at risk or will go on to get severe dengue is a priority of research for us. And we know there are certain at-risk groups. So patients that have had dengue in the past. So if you get one of the serotypes, you're only immune to that serotype, and you are still at risk of getting one of the other serotypes. And initially, after you've had one infection with dengue, you are immune to all of them. But then as your antibodies wane after several months or years, there's a window in time where you are at risk of this phenomenon called antibody-dependent enhancement, where if you get a second infection, rather than neutralizing that second infection, the antibodies from the previous infection actually facilitate viral entry into cells and can then give you higher viral loads, and then you're at risk of more severe dengue. So we know secondary infections are a risk, but also there are other risk factors. So age, kids are more likely to get shock, and that's a combination of them having more leaky capillaries, but also they're less likely to be able to compensate. And then other patients like those with diabetes and hypertension, and patients with obesity. So similar to the sort of risk factors that we're seeing with severe COVID now, for example. So we've done a few studies looking at risk factors for severe outcomes, and we've looked back at, again, a pooled data set to see what this association with viremia is, and we found that higher viremia did increase your risk of developing all clinical endpoints, and that was across different age groups, serotype, and immune status. So this work was done by one of my PhD students a couple of years ago, and you can see here the different serotypes, so dengue 1, 2, 3, 4, and then the outcomes, so probability on the top of developing severe dengue, probability of severe leak, and hospitalization at the bottom. And you can see that higher viral loads are associated with all three clinical outcomes. And then we also looked at biomarkers, and we looked at CRP first. This was a study we did that was funded by the WHO and was part of an observational study that was run by Bridget Wills in, I think, 6 or 7 countries in Asia and Latin America. And we looked at whether CRP could be used as a biomarker. And we did find that your higher your CRP, the more likely you were to have intermediate severe dengue and hospitalization. So again, these are various different outcomes that we looked at. So we know that higher inflammatory markers could be useful to use as biomarkers, but we also wanted to find some other biomarkers because we know that the pathogenesis of dengue is complicated, and we looked at various other vascular and immune and other inflammatory markers in a bigger biomarker study, and we looked at those that would be likely to be raised early because we wanted to catch patients in the first 3 days of illness, because we wanted to really see which patients would go on to get severe disease. So we didn't want them to be already in a critical phase, which is day 4 to 6. And we looked at VCAM, angiopoietin-2, SINGACAN, which are the vascular markers, various immune markers that you can see there, and then also ferritin. in combination with CRP. And again, looking at individual biomarkers, nearly all of them were up earlier for those that went on to get more severe dengue. But what we were interested in was whether we could combine 2 or 3 of them, and then with the view to developing a rapid test that we could then use in the outpatient clinic, for example. So we looked at different subsets for children and for adults, because we know that pediatric dengue clinically has a different phenotype to adults. So we didn't think there's going to be a biomarker that would fit all. So we looked separately at pediatric and adult, and you can see the different combinations and which ones were the best. And we're working now with Roche to see if we can refine these biomarkers, and they're looking at various others, and again to see if we can get a combined rapid test to help with triage. So yeah, these were the best combination that we found. So in children, it was the combination of IL-1RA, angiopoietin, IL-8, ferritin, and IP10, and adults were slightly different. So moving on to potential therapeutics. So we're using all of the information that we've discovered over the past few years, especially on the pathogenesis studies and the biomarkers, and thinking about what pathways are involved in dengue to see if we can develop host-directed therapies. Currently, we don't have any. So these are the previous trials that have been done in dengue, mostly in Vietnam by my predecessors, but also some in Thailand and Singapore. And those are the drugs that have been trialed, and none of them have shown any benefit for changing clinical outcomes. So what I'm trying to do now is, rather than give drugs to all patients, is really to just target patients either by risk group or by a specific pathway that is already activated. And I'll show you one trial that we're using. We're going to use Anakinra, which is a IL-1 receptor antagonist, but we're only going to use it in patients that have evidence of hyperinflammation. And we know that those that have high ferritins and CRP are at higher risk. So what are we trying to achieve with dengue therapeutics? So for antivirals, trying to reduce the time the patients are viremic, but as I said, by the time a patient presents, they're already, it's likely that they're already peaked their viral load. So, you know, getting the drug in early is going to be key, and I'm not sure any of the antiviral trials that have been done before have really been able to get in early enough. So similar to influenza, if you can't get it in within 48 hours, there's really no point giving an antiviral. And for host-directed therapies, again, got a bit more leeway in time. So, but it's just when to give them, and would they impact on viremia if you're taking out, for example, if you're giving them an immunosuppressant. So just quickly mentioning 3 of the trials that we're doing. One is using metformin, and we're targeting patients who are at risk by because they're obese. So we have quite a big problem with obesity in Vietnam, especially in kids. So, and we know that they are at risk of developing severe dengue. So we're using metformin because we know metformin has some antiviral properties from mouse studies through AMPK activation, but it also has immunomodulatory properties. It kickstarts the sort of NK cells, and also it has vascular sort of stabilizing properties. So we're hoping the combination of all of these mechanisms would impact dengue outcomes, and we are giving that to patients up to 72 hours of illness. That's ongoing. It's been a bit slow because of COVID, but we're hoping to finish that this year. And then Anakinra. So this is what I mentioned before, and this is actually funded by the Wellcome Trust, and what I'm doing for my clinical career development fellowship. And we're going to be doing lots of sort of mechanistic studies alongside this trial. And yeah, we will be screening patients. So we're only going to give Anakinra to patients with dengue and signs of hyperinflammation, which is defined by ferritins of over 2000. So that will hopefully start this year. It's just gone through the IRB in Vietnam. Antivirals. So last year, this was published in Nature. It's an NS4B inhibitor developed by Janssen, and so that has now gone into a phase 2 trial, and it started in Singapore, and we will be the other site. So we will start this also this year, and again trying to get this antiviral in within. We're trying for 48 hours of fever, but up to sort of 60 hours is probably more realistic. And this is currently the only antiviral trial that's going on. So yeah, dengue therapeutics. I mean, I think what we really need to achieve is to prevent these kind of scenes where wards become completely overwhelmed with patients. So trying to get patients out of hospital earlier, so even by reducing symptoms, maybe stopping people go on to progress. But we also need something for those patients that do end up in the ICU, where we currently have absolutely no options for treatment. And then I'll end up just by touching on some vaccine and controlling dengue work. So vaccines, you may have heard that the first dengue vaccine was licensed a few years ago, Sanofi Pasteur, and initially there was lots of excitement, and then we realized that actually from the long-term follow-up studies, patients who were naive, so had not had a previous dengue infection, seemed to have a safety signal about 30 months after their vaccine, so they were being hospitalized more. So the license, so a lot of the countries withdrew the vaccination program. There was a big hype in the Philippines where people were very upset because there were a few deaths. And it seems like what has happened is that patients who had not had dengue in the past, so who were naive, because the vaccine does not give pan-serotype efficacy, so there was less. It was less effective for dengue serotype 2. It was then predisposed you to getting like a secondary dengue infection, which meant that you were at risk of having more severe dengue. So now it's only licensed for patients who are seropositive. So you have to have an IgG result before you can get the vaccine now. And you can only have it if you're IgG positive. So it's really hard to do any kind of countrywide vaccination program now, because doing a blood test before every vaccination is really sort of prohibitory. So that was a shame. Takeda, which is the next vaccine that will, I think, about to be licensed, and it's showing much better efficacy and more balanced. So we're hoping we won't see this problem of long-term safety. And this will be, as I say, hopefully licensed this year. And there are various other vaccine candidates in the pipeline. So currently the only way to prevent dengue is through vector control. And it's usually just environmental, so getting rid of all that sort of household rubbish and all the mosquito breeding containers around the house, improving water systems, mosquito proofing water storage containers. Because interestingly, a study in Brazil showed that actually in the dry season, dengue seemed to go up, and it was because people were storing water around their house more in open water containers, so mosquitoes were able to breed. And during outbreaks, you can use adult insecticides, sort of spraying or fogging, which anyone lived in Singapore or Malaysia would know that people going around fogging it around apartment blocks every few days can be quite disruptive. It's also quite expensive, and in low middle income countries, it's just not feasible to do that. This is what they look like. it's extremely noisy, and you can it doesn't last. So within a few days, the adult mosquitoes are back. I'm going to just end on something that is quite exciting, which is this Biocontrol using Wolbachia, which is an intracellular insect bacterium that is naturally occurring, but it's not found in Aedes mosquitoes. But when you do introduce it into mosquitoes, it can actually block viral transmission. So the World Mosquito Program are using this now as a way of trying to, well, initially was called eliminate dengue, but now I think certainly will impact the incidence of dengue, and not about elimination. So when Wolbachia is introduced into male mosquitoes and they mate with female mosquitoes, all the eggs are sterile, so they won't hatch. So some countries are using that as a way of just sort of suppression of the mosquito population, but again, it's not sustainable. But when you introduce it into female mosquitoes and then they mate with male mosquitoes, all the eggs also carry Wolbachia. So eventually, the wild-type mosquitoes get replaced by Wolbachia-carrying mosquitoes. And this is what it looks like when you have repeated introductions of female mosquitoes carrying Wolbachia. Eventually, it's self-sustaining, so it is sustainable and much cheaper. And this is some work we did in our lab. At the bottom panel, which shows wild-type mosquitoes and those carrying Wolbachia, and you can see the viremia in the saliva of those mosquitoes is completely, or almost completely suppressed in the Wolbachia containing mosquitoes. And then this was a randomized control trial that was done in Yogyakarta in Indonesia that was reported and got quite a lot of media attention last year, which was quite remarkable actually. And we've not really seen anything quite like this in the dengue field anyway, that showed a reduction of dengue incidence in those areas where mosquitoes have been released carrying Wolbachia. But yeah, there was a 77% reduction in dengue cases in those areas. So really quite remarkable result. Even the study team weren't expecting such an amazing result. And that again, through the World Mosquito Program, we're well funded. There are various ongoing rollouts of these mosquitoes in Latin America and in Asia. So just to summarize what you've heard, dengue is now the most abundant vector-borne viral disease, and it's increasing with climate change and urbanization. There are these distinct phases that impact on management and also diagnosis of the disease, and there are certain people who are at risk of developing severe dengue, and severe manifestations are mainly shock, but also bleeding and organ impairment. And currently the management just relies on really meticulous fluid management. And we are currently trialing various therapeutics and innovative technologies, but there's nothing at the moment that's licensed. And so the control still relies on vector control. And this is my team. It's quite an old picture now in Vietnam, with collaborators and my funders. And if you want to hear more, drop me an email. And if you want to know more about the Innovations Project, that's the website, if you want to look it up. And yeah, I'll finish there. Thank you.
Thanks, Sophie. Wonderful, really wonderful talk, and a really broad-ranging set of subjects. But I mean, the research you guys are doing is really amazing, and it was wonderful to hear about it. Thank you. I don't know if you're able to stop sharing your screen. If colleagues would like to ask questions, could you please pop your hand up in the chat? I'll just start off while they're thinking. I mean, there's so much, there's so many questions. I mean, one question from me is, with your clinical decision support system that you're developing, are you using AI in terms of bringing in the cases that you've previously seen to try and help predict which is more severe or less severe?
Yeah.
Okay.
Yeah, exactly. So that's the sort of data, the retrospective data set that we were using from OCRU. All the patients that we've ever recruited into a trial, we're using those patients. And then we're also, once it's developed, we will be inputting new patient data and also trying to incorporate some of the physiological data, the continuous wearable data that we're collecting as well. But yeah, that's the what we've been using the machine learning algorithms for using the data that we've already got and the patients that we've got. And it's based on a system that's already sort of up and running at Imperial, but they're using it for sepsis, and we're just adapting it to the dengue patients.
So I mean, the test, ideally, if you're seeing thousands of patients in the outpatients, you're going to need a dipstick test or a point of care, something that will, you'll be able to do very rapidly. Is that where the innovation is moving towards, or are you not there yet?
You mean for diagnosing dengue, or for the sort of
deciding who needs to be admitted?
Yeah, we're not quite there yet. I mean, for diagnosis, we do have those rapid NS1 tests, they're not great, but for risk prediction, we're hoping that we would be able to get, as you say, a rapid test which incorporates 2, maybe 3 of the biomarkers that we've identified to help triage. But yeah, we're not quite there yet. Okay,
no, thanks. I'm not sure if there's any of our colleagues on the line from the NICD, from the arboviral group. If you are, it'd be really interesting to hear your comments. But we've got 2 hands, so Sean and then Sipo.
Hi, Sophie. That was a really great talk. Thank you very much. What's really striking is that endothelial dysfunction seems to be a kind of common pathway in infectious diseases leading to severe illness, right? I mean, clearly in arboviruses, but also across other pathogens like malaria. And now we've seen with COVID, right, with endothelial dysfunction. And so I'm interested in your thoughts just generally about that. If there is a true kind of final common pathway across infectious diseases, or if you think that there are kind of subtle differences or specific differences in kind of physiology across different infections. And then kind of linked to that is, why do you think ferritin is elevated in severe dengue? Thank you.
Yeah, that's a really good point. Something that we've been asking as well. And we're doing actually a study of endothelial function between dengue and sepsis at the moment, because we don't see malaria, but obviously that is also one. And just looking at the sort of comparing in the literature, I think the striking thing that we see in dengue patients is the sort of shearing off of the glycocalyx layer, which is, this layer that sits on top of the endothelium. And we see really high levels of syndecan and heparan sulfate, which we then think would be would change the capillary permeability properties. And that seems to be higher than some of the other infectious diseases, although it is shared in many other infections, especially in sepsis. But it could just be that because we know the virus actually binds to heparan sulfate in the endothelial layer, that it's just the magnitude of that loss of that layer. But you're right, across the board there are, the endothelium is a target and is dysfunctional, yet clinically these diseases are completely different. But yeah, so that was one theory, but we will be looking specifically at dengue and sepsis in the same cohort and with the same techniques, and hopefully we'll be able to answer, because comparing our studies to studies done in other parts of the world with different techniques and in labs and whatever is always hard. So yeah, we'll hopefully be able to look in more detail at that. And from the ferritin side of things, yeah, I mean, we know that sort of the whole inflammatory sort of pathways are activated. We don't know exactly where ferritin is coming from. I mean, they do get liver dysfunction as well, but it's not, some patients will have ferritins of 12,000 and with relatively normal liver function. So we think it is probably just part of like a macrophage activation syndrome, and part of that whole pathway. And if you want to read more, we've also just published in JID last week about the macrophage activation syndrome and NK cell function and ferritin in dengue. So have a look at that.
Thanks very much. I mean, I think Kevin Kane's done a lot of work with malaria and endothelial factors, angiopoietin. I mean, is that a marker that you're looking at?
Yeah, Ang2 always comes up as one of a really good marker for dengue, and I've spoken to Kevin about his work. S-trem was also one that he found to be very useful. We haven't found that S-trem was that useful, but Ang2 always comes up, and then the ratio between Ang2 and Ang1. Yeah.
Great. Sipo, I think you had your hand up. I'm not sure if you've put it down.
Yeah, no, thanks, Mark, and thanks very much, Sophie, for your presentation. Mine was similar to Sean's, but I think I was just going to ask you, in just relation to the inflammatory phase of the illness in terms of the therapeutics. Just like we've seen with COVID, it looks like it's not just only one inflammatory pathway that's activated, and whether you should be looking, or have you considered in dengue looking at switching of multiple pathways at the same time? I know you've talked about specific molecules for specific pathways, but any thoughts about combination therapies during that phase of the illness?
Yeah. I mean, well, when they did try steroids, which I guess would be sort of broader immunosuppression, it didn't impact outcome, and that they use it early using prednisolone, and then later in established shock using hydrocortisone. But I think for that, it was the patient selection that was the problem, because they were using it for all patients. And I think we have to be more targeted and only target those patients that have this sort of more of the hyperinflammatory phenotype. So whether it's worth addressing that again. The only other drug, I suppose, that's a bit more broader was baricitinib, is another drug that we are considering using, again, just targeting those with the sort of hyperinflammation. But I guess that's, again, a bit broader than just taking out the IL-1 pathways. But was there anything you were thinking of, or?
Nothing comes to mind. I was just asking just your thoughts on that, because it's just interesting that we've just learned in the last 2 years that it's not going to be one pathway during these hyperinflammatory syndromes, and the data certainly for COVID suggests maybe multiple pathway blocks seem to be the way to go, rather than just targeting one part of the pathway during this hyperinflammation. I mean, the question really is understanding why it happens, right? Rather than trying to block multiple pathways. But I think the science isn't there as to why it happens, because that's the answer. Understanding what the switch is then allows a more targeted approach, I suppose.
Yeah, no, exactly. And we have done a lot of sort of groundwork, and I think at the moment the best data we have is pointing towards taking out IL-1 to stop that sort of just that cytokine storm. And whether that's going to be enough, I don't know, but we'll find out. And as I said, within the trial, the Anakinra trial, we'll be doing lots of mechanistic studies and trying to understand, and hopefully that will shed light on other pathways as well. So we should learn more during this trial.
Thanks, Sophie. I think just we do have, I think, Orienka from NICD from the arboviral group. I'm not sure whether you have any comment on this or anything to share, Orienka.
Hi, Mark. No comment at this stage from my side.
Okay, you've been blown away.
Yes, it was amazing.
Just a last quick question. Really going back to the epi, and is the reason we don't have those explosive epidemics in Africa? Is that really about, you know, the urban versus rural issue? Is it about the mosquito? Is it is it multifactorial? I mean, we're not very happy that we don't have them, but it's interesting that we don't.
Yeah, it is interesting, and it may be that there is also some genetic protection. So whether there is, I mean, they've only really done one genome-wide association study that was based in Asia, but it may be some genetic factors, or as you say, the mosquito, the epidemiology, but the fact that even in the sort of densely populated urban centres in Africa, you don't see these huge outbreaks, or you don't see the severe disease, is interesting, and I imagine it's a combination of factors, of which some form of also protection from the sort of genetic factors does play a role, but it's certainly, yeah, we don't know, and whether it's something that could emerge in the future. I think there are only studies being done in West Africa really trying to understand the sort of mosquito viral transmission and what's happening. There's also, there are some Aedes species in West Africa that actually don't transmit the virus, which is interesting. And I know IP Institut Pasteur in Paris is looking at that and why that should be the case. So at the moment, there are lots of theories, but there's not much evidence to back them up.